This is the ABG series scenario 6 brought to you by the Medicine Project. Let's have a look at this case. So, a 67-year-old diabetic male was brought to the emergency with complaints of altered sensorium, palpitations, and breathlessness. The patient had multiple episodes of loose stools after eating at an outside food joint. The patient is on metformin 1000 mg and glyclazide 60 mg daily. On examination, the patient appeared dehydrated, sick, and confused with fruity odor in the breath. Chest was clear, PP was 120 by 68, pulse 110, sugar 346, and a bedside ABG revealed the following. So pH was 7.28, PaCO2 30, bicarbonate 14, sodium 138, and chloride 112. Please calculate the anion gap in this case. Okay, so let's describe the ABG disorder and the management of this patient. So this patient is a case of high anion gap metabolic acidosis with normal anion gap metabolic acidosis. Now this may seem extremely wrong, but let me elaborate this in a proper way. So this is a case of metabolic acidosis that is associated with high pathological anion concentration and masking of the gap by an increase in concentration of another anion like chloride. Let's understand this now. So when we assess the patient, it is evident that the patient is having ketoacidosis, which is a high anion gap mechanism. But calculation of anion gap will reveal the value to be around 12, which is nearly normal. Now, if we see the delta Ag here, it is nearly 0 because there is virtually no change. Now, if we check the bicarbonate, we'll easily notice that the fall in bicarbonate is out of proportion to the change in anion gap. If it were pure high anion gap mechanism, the fall in bicarbonate should have been corresponding to the change in the anion gap, which is not the case here. This means that the anion gap is appearing normal due to compensation by another anion in this case, which is getting increased. In this case, the bicarbonate is getting lost by two means. First is diarrhea, and in diarrhea, it is being compensated by an increase in chloride. Secondly, it is getting consumed to buffer the keto acids. This increase in chloride is what is making the anion gap appear normal. So basically, this is two separate processes that are producing this ABG report when they present together. So the management protocol is based on DKA along with fluid and electrolyte correction, IV insulin infusion with early antibiotic cover, prevention of fluid losses is to be done. Infusion of Ringer's lactate or plasmolite should be preferred over NS because NS can worsen the NAGMA component here as it contains a lot of chloride. Electrolyte monitoring and airway, breathing and circulation maintenance is to be done. Please like and follow. Thank you.